She had traffic on 64, but she'll be here.
Is there someone else coming in person? They didn't let me know.
Dr. Goose.
Yes, Dr.
Okay,
Goose.
I thought you said someone else with a female name. I'm sorry, I was eavesdropping. Right.
I, on purpose, came up to Western Kentucky in the bluegrass just because of that.
Yeah.
Little Coach Close Run. 64 can become a parking lot so
Oh, yeah.
quick.
You know, sit there all day.
Hmm?
I wonder if they have any MCO.
I don't know, that's what.
I don't
That's what
see
we're-
it.
Correct. Amy, I'm sorry to interrupt. Do you know if we should contact Megan and have her?
Commissioners, are we ready to go?
We're ready to go.
All right, can everybody over there hear us?
Can you guys hear us okay?
Hey, so get a thumbs up for Mary. Okay.
Well, good morning. I'm Dr. William Thornberry. This is the Physicians Technical Advisory Committee. This is September 16, 2022. I have 10:04 local time. Here in person, we have Commissioner Lee. We want to thank the Commissioner for taking her valuable time and joining us. I have our Emeritus Chair, Dr. Neal, and myself. We're expecting Dr. Gupta. We have Dr. Linden on television, which gives us our quorum. Dr. Linden is our new psychiatrist from Louisville. He's our newest member. Welcome, Eric. Thanks for joining us.
Thanks for having me. Glad to be a part of the group.
Yes, sir. Are there any discussion, additions or deletions to the minutes of our previous meeting? There being none, I'll accept that as approval. Our old business, we have a couple of old business items. The first was the timeline of change that DMS looks forward to in a change of 907 KR 3.010. That's the level 3, level 4 office visits. Do we have somebody to speak on that behalf, or do we have a timeline? Well, Ashima, welcome. Just your timing is excellent. Since Dr. Gupta has arrived, we can now really begin. And so, do we have anybody from the DMS side that can give us a bit of an update? We've been kind of working on this for a couple of years. Does DMS have a plan for updating that administrative regulation?
Is Jonathan on in the meeting?
I did not see him log in. Let me see. No.
We do, I would have to follow up with that, and I can do so in writing if you want me to. We are making that change to the regulation. We thought we had it made prior in the regulation, but I do believe that the MCOs are already paying for those changes. And we are updating the system, but I can get that timeline for you and follow up in email. That's
So they are paying it, which is the critical part.
yeah.
Okay.
But the actual regulation, because that's the one good thing about having the MCOs, they have a little bit more flexibility than we do in the fee for service arena. So as soon as we get that regulation filed and updated, I would, sorry, I don't have that timeline with me right now, but I know that it was ready to be filed, and I may have even, signed off on it the other day.
Can you work within the back channels on just kind of making sure that we offer our support there?
Yes.
Very good. And publicly, I want to thank Lisa we have on board. I know we have Humana and Aetna on board. We'd like to thank the chief medical officers there and your leadership for supporting us in this effort. Again, this is something we're trying to do to keep our primary care and our physician providers solvent at this time. I'm just going to move us on to item 2, which was the extended coverage. We talked about contact lenses. We were working, I think that's an issue Dr. Gupta kind of pointed out for ophthalmologists. We worked on it last time about the provision Shima, where are we at with that?
Actually, we did receive a notice from DMS, I think last month, that it's under review. They're gonna let us know within 90 days. I think the actual recommendation that I had emailed was about the serum tiers.
There was two,
Right.
there was this one, which was the extended Medicaid coverage for medically necessary contact lenses, which I believe DMS had extended for 90 days, and then the other one was serum tier coverage.
Right, that I wanted to try
Under
to,
Medicaid.
I would like us to try to make that recommendation, because it was, although we discussed it like in the winter time, we never made a formal recommendation. So I'm actually just trying to find that email that I sent you where I saw it this morning, but where I actually wrote out the recommendation from PTAC. Just looking for that.
Do we need to do that today?
Yes, if we could.
Okay.
I'm just finding, I've written out the recommendation.
And so what was the logic behind that?
So this autologous serum tiers is for patients with severe dry eye syndrome,
Mhm.
and it is not covered by insurance. It's about $300, I think, for about, a 12-month supply. And thank you. And so not all patients need that, but patients who have really severe dry eye, like due to rheumatoid arthritis or side effects from cancer treatment. So it causes severe blur and pain in the eyes. And in some of those patients, the only thing that will help would be autologous serum tear. So they draw the blood from the patient and then they spin it down and they make these teardrops for those patients. So, and a lot of these patients that need it, they're on a fixed income, they can't afford to pay out of pocket for it. So the Kentucky Eye Bank, that's who's, along with some of the cornea specialists in Kentucky who, provide the service to patients, they reached out to me to see.
So what would happen is a patient in that group, that Sika syndrome, or that group would be, they would have tried other methods, obviously.
Yes.
And the sliver of cases would be, you're talking about, I mean, there's not a few hundred people here, are there?
No, it
It'd be-
probably would not. He actually, Bradley Tennant from the, he's a CEO. He just sent me all this information about it, but you're right, it's a small sliver. We don't have the exact percentage.
We're not talking thousands, we're talking a few hundred or
Yes.
tens of people a year,
Right,
just to give them some type of weight on that.
right.
Okay. Well, Eric, do you have any discussion on that matter, Eric?
No, I don't.
I
Okay.
do know when we looked into, hi, this is Dr. Terrio. When we looked into this back, I guess last year, it's still considered experimental. And even though I know we do it for a lot of people, or a lot of people get this service, it's still experimental. And I don't really think we can cover things that are considered experimental.
Dr. Terry, you are absolutely right. It is considered experimental, and that is probably the main reason why no one covers it. But this, I just bring it to the attention because it is an issue, and it will definitely hinder people's productivity. So, they also look for grants and things like that. They really need about $500,000 to support 2 years of service. So, I know.
There are a lot of problems to solve. I'm not sure that's one that,
Right.
yeah.
They asked me to bring it to
And I
our
think
attention.
I think we certainly at least see it on the radar. And at some point in the future, maybe it won't be a position we can revisit that.
Right.
I would ask them that the corneal group to nudge us, on a regular basis. And maybe they could kind of be monitoring that.
Mhm.
That's what I would think. We do have a lot of, I guess we have a blanket and we only have so much, so many toes I can cover with it.
Right.
Yes, ma'am.
Okay.
Thank you. Let's move us on to new business.
This is Justin Derringer with DMS. I just wanted to give a quick update of where we were with, just to let you all know where we were in the process of those extended Medicaid coverage. we're working on right now, finalizing the pieces of all those different codes and procedures and processes, looking at various other states and working with Medicare and different resource groups to come up with those exact fee structures. And we've already got a draft of the state plan amendment ready, and we've already started looking at the regulatory changes. So we're pretty far along in that process, and just wanted to give you all an update on exactly where we were with adding all those extended Medicaid coverages.
Is that for the contact lens coverage? Is that what you're talking about?
That's
Just-
one of the items that they're looking at. Yes.
Okay, thank you very much.
Thank you, Justin. On our kind of our items 5 and 6, these kind of, I think to frame this properly, the commissioner came in a little early. And before we logged on, we were talking about, well, what's the feel of the general medical community? And this would be, I think these items are all, though we talk about separate factions of the items, I think they're the same item. And this is, I think, the concern of the medical community. We have really 3 players in this game. We have DMS, who's kind of a referee. We have our MCO partners who are here to provide the care and be solvent in providing that care. And then you have the physician community. And in the physician community, obviously there's a business interest to try to stay solvent. But I think part of what that community is trying to share is we're trying to find a sustainable way to provide care for the Commonwealth, not just for today, but for the future. I was driving in this morning and I thought about an analogy that kind of at least makes a little sense to me, and I'll share it with you. And I hope it's reasonably appropriate. I was thinking about my children had gone to summer camp and they were swimming out there, 2-4 foot water, and they made this on. Everybody's having a good time. And over on the side, they're some of them swimming, good swimmers, some of them not so good swimmers. But on the side, I got this one kid over here, and he's swimming in about 4 or 5 foot of water. And then the lifeguard comes over and says, well, we want you to put on some jeans. And he starts struggling with this swimming. And then he says, I need you to put on a shirt too. And it becomes more difficult. He says, I need you to move back to the 10 foot water. Then you go back to the 10 foot water. Then he says, well, listen, I want you to put some shoes and socks on in this backpack too. And then they start filling the backpack with rocks. And I think what we're seeing here is an existential crisis in your primary care. And if we don't help you understand what we're seeing and hearing, then we're not doing part of our job. And this really came to kind of a head this week. A couple of weeks ago, we had KMA, and we invite several very senior leaders from adjoining states. And one of these leaders is a primary care person. They said, we border your state, we take care. There's 2 counties that don't even have a physician in Kentucky. We have 8 providers. We take care of these. He goes, at the end of the year, we're going to stop. He goes, and I apologize for being direct, but I want to try to paraphrase. He goes, your coverage is not just bad. He goes, we have bad coverage. He goes, your all's is terrible. And your prior authorization is just, that's the end of it. He goes, we just can't do it anymore. And so what we're telling you as a workforce is the rules that we've had are, for good or ill, what it looks to us like, and what I'm hearing repeatedly, and you correct me if I'm wrong, Dr. Neal, you have much more experience than I do, but we're getting into a position where now we can't really provide the coverage. For example, in my office, what we're obligated to do is the primary care is I would say the cough and cold that we get. Well, that's less than 5% of my cases. I mean, it's certainly less than 10. Really, what we do is we do moderate complex care. Somebody that's had a thunderclap headache that started a couple of weeks ago and they still have it, and these people don't have headaches. Well, somebody comes in and tries to have some sutures. I want to keep them out of the ER. There's no reason to have them over there to jack up the bill 10 or 100 times. But this moderate complex care that we're getting is more the norm. And then we're obligated with chronic disease care. So it's just when chronic disease care goes well, we're still obligated to take care of the lion's share of that. But when it doesn't go well, the exacerbations, we're in charge of that too. And then we're trying to work around a system where we now have these people that have gone through, much like physicians and your all staff has gone through this kind of trauma of the pandemic. Well, these people have lost a lot of less resources, and their Maslow's hierarchy of needs is very modest. Their social determinants of health are beginning to crumble. And so we have all these social problems. Whatever their problem is that brought them into the doctor, that's the tip of the iceberg. They have other major problems. And we're trying to solve all this for you. We're trying to do it in a way that's going to make us sustainable. And I think, for example, just with the prior authorizations, which was the first topic, what we're saying is, well, I know to DMS, maybe not to DMS, but to some people, it looks like, well, we don't want people ordering things they don't need. You know, from our point of view, we have a kind of a mandate called Choosing Wisely, where we train our medical students and we try to govern ourselves properly, not to order things that are unnecessary or unhelpful. In my office, when we go to order something for Medicaid, my girl just gives me what I would call the look, and we just capitulate. We just don't even try anymore. But it doesn't mean the patient's not going to get it. See, that's the problem. It's going to cost us more because I have to send them over to the ER. I had to call yesterday. I said, Dr. Carter, I got to send this patient over. Here's what they're going to need. Or we send them to the urgent clinic. It's not really an urgent clinic, but they're really an ER. They're just urgent clinic by name, but they're an ER on paper, and they're going to order these things for us. And now we have to, like when I go to, say, a specialist, a consultant, instead of ordering the stuff that they need before they get there, I'm going to have to send them there, get the consult, have them go back, order the things that they need and come back. And so these things are being done. It's just in a much less efficient way. So I guess what we're trying to tell you is, we're going to try to ask you to try to find a way to help us do our job. And I'll be fair-minded if I can. I don't expect that all the providers are going to have the privileges to order what they want, whatever they want. That's not sustainable. Because I think that what we're learning with Hattiesburg and Kaiser Permanente is these physician extenders that have come in and told everyone that we can handle this job. Well, they don't seem to be able to handle this job. Maybe it's their education, maybe it's the amount of experience they have with patient care. But our problem is when these people are running the ship, they don't run it economically efficiently, and our Commonwealth is going to have that. So that's what we're trying to show you in some of these things that we're demonstrating. The first issue was that was discussed in our pre-meeting was during the first year of the pandemic, we waived the prior authorization. Did DMS, now that they can look back a couple of years, do they have any insight into, was that a catastrophically bad thing to do? Did it, because it helped us solve a lot of problems, was that, how did DMS feel about that? Do y'all have any, and maybe you don't have any data on that, but we were interested to say, well, when we did do that, when we opened the reins completely, well, what's the difference? Was there a delta there? Was it a substantial delta? We understand that one or two people in our field, in every field, are not going to do the right thing. But no matter what the rules are, they're not going to do the right thing anyway. You know, so when we did that help? Because that would help us immensely in trying to solve our problems for you. Cody, am I leaving anything out here? I want to make sure that I'm covering it. Yeah. And I want to cover it in a fair-minded way too, because again, we don't just represent ourselves, we really represent the Commonwealth, and I'm trying to think about the viability of this, again, now, 3 years from now, and 10 years from now. I don't know if anybody from the department has any insight into this or would like to chime in on it.
Yeah, we haven't run the reports to look to see during the period when we waived prior authorizations, what were the outcomes for those members. We have been looking at some of the information, but mainly on the behavioral health side. For example, we know that some of the stays in some of the behavioral health facilities were lengthy, more lengthy than they were prior. So what I would recommend for this committee is to help us design a report. What do you want to look at? What can we give you to kind of help see, were there specific services where prior authorizations were waived where individuals had better outcomes? And I mean, it's going to take us a little bit to get those reports, but we do work with our universities to help us actually pull that data and analyze it. We can pull any report you want. We can start looking at top procedure codes, top diagnosis codes. We can look by region. So help us design the reports that you want to look at to help drive some of these policy decisions. And I will tell you the other thing that we are doing is we are looking at the physician's fee schedule. We are looking at that. I don't know if you know how we do our fee schedule every year. We kind of add codes and we price them based on the Medicare rate. We sometimes don't go back and update codes that have been on our fee schedule for quite some time. So we're now looking at that entire fee schedule to see what's the impact is going to be if we update that entire fee schedule. We think some codes may increase, some codes may decrease, but those are the things that we're kind of looking at. But we're going to need this committee's help to help drive those policies once we start looking and seeing impact. But I would definitely like to hear what you all want to see in the report field to help us look at specific, what are our top issues with delivering our primary care services? What services are our providers actually delivering? What should we be delivering? And how can we, when we start talking about procedure codes and fee schedules, it's so difficult to just give an across the board raise for fee schedules. But if we start honing in on some of those top procedures that we think need a little bit more attention, we can start doing this, taking baby steps for our program. And I think, and just hate that it's taken us a little while, but the E&M codes, the 99213s and 4s, how we're changing that process. That's, to me, is a small change with big impact. And how can we make some more small changes with big impact? And what data do you need to help us focus on those small changes that will deliver that impact?
I think that would be greatly appreciated. We certainly are trying to struggle through just in today's news, inflation. If you sell an apple, you can raise your apple 5% or 10% if you have to. Well, we don't raise our fees. Yet in our office, we had to give, just last month, we had to update everybody's pay schedule so that we could retain our staff. And that doesn't go away. Obviously, the cost of living doesn't go away. So we would appreciate that forward reaching, Dr. Neal.
Well, I ask that it be put on the agenda that we talk about who's taking care of our Medicaid recipients. This has really changed, and I want to get away from reimbursement. I want to get away from prior authorization a bit and understand from you all what you understand about who's taking care of Medicaid recipients in Kentucky, because the primary care workforce is changing rapidly, and we're standing at the edge of a cliff about to fall off is what's happening. Because when I went into practice 50 years ago, it was all individual physicians. It gradually became groups, and then we started to train nurse practitioners. A lot of things happened. But that's what I'm hoping you all are looking at and talking about, is who's taking care of people, because now we've gone from the rural practices that were mostly physicians that would see Medicaid patients. Now we have federally qualified health clinics, and almost all the rural care in there is federally qualified health clinics. Correct me if I'm wrong, because I believe that's what's happening. And of course, they have a totally different pay schedule because they've got cost plus, which throws in a whole dynamic. But you all need to understand, and I hope you are, that the workforce is changing. 75% are approaching that of primary care physicians now are female. Okay, that's wonderful, except that they're also mothers and they're generally working part-time. This is also happening in the dental field. And so the number of practitioners may actually be increasing, but the work days and hours is decreasing for all of them. Not to even throw in what's happened with the electronic medical record, which has thrown us from being able to see 40 patients a day in primary care, particularly in pediatrics, down if we're lucky to see 25 or 30 a day. And so who's going to see it? What's going to happen to access to care? And I think that dynamic is changing enough that we need to be helping you all to understand. And that's why I asked that it be put on there. Who's seeing Medicaid patients in Kentucky, and what do you anticipate in the future? Not even looking at reimbursement, because as we said, what are we at, 75% of Medicare or something like that? That's just absolutely pitiful. Florida was only able in the last a few years to bring for a temporary increase from Medicaid to Medicare rates for primary care doctors in Florida, for example. And that's the only thing that's kept Florida going as far as seeing Medicaid patients in Florida. I just use that as an example, as some way to possibly change things. But I really, we're looking at training. We're not even filling the residency programs in primary care now. The most apropos thing I heard at the KMA meeting is they talked about reducing the medical school training from 4 years to 3 years. And they were saying, no, with the complexity of what you're seeing in your practice, particularly in Medicare patients, is that they're not even learning until the 4th year the way to take care of the more complex patients. And so we're worried about the training of physicians, much less the expertise of nurse practitioners who have like 10% of the training. I trained nurse practitioners for 30 years and they're wonderful folks, but are we going to end up with all the Medicaid patients being seen by nurse practitioners and them not have access to the quality care that they should have?
And I would be
I could
okay with
ramble
that.
on a long
And
time.
I would be okay with that if it worked, if the model worked, if we had physician assistants or practitioners, if they actually were the front lines. Several decades ago, that was the vision of, we thought that's the way our medical community would work. But as, again, I think very early on, 10, 15 years ago, Kaiser, it almost put them out of business. And they stopped doing that. And then the most recent data was just a couple months ago, Hattiesburg, Mississippi, where that was a very, very strong study of people that were in the same health system with the same resources. It's just some people had oversight with an MD and some people did not. And these were people working in the same building in the same office. And there was a dramatic shift. And I would ask you all to look up the data yourself. You don't need to listen to me. But I guess what we're trying to say is these things are, when we look at global issues, think of this, I have 3 medical schools in Kentucky. And firstly, we can't even get them to fill their, and we're in a state that needs primary care, we can't get them to fill the primary care spots. And what's worse than that is we export doctors, we train doctors for other states. They leave our Commonwealth because they don't want to practice here, you know? And the more challenging it becomes, the less they move forward. And this is a very deleterious sink that happens, because as you destroy the primary care workforce, so you have, let's say, primary care doctors like Dr. Thornberry, where there's no mentor for the medical student to come in under. And when there's no mentor to say, well, there's no really, I don't see a real place for me, I can live really anywhere. I'm going to go to Texas, or I'm going to go to Tennessee. But then it becomes more of a, beyond this level, becomes a political problem for somebody in the executive branch saying, well, why are we paying for these medical schools and taking our Commonwealth people's money if they're not even going to stay here? And somebody's going to have to answer that at some point. But we're saying is, again, who's taking care of these patients? The ophthalmology patients from almost where we're going to Bowling Green now.
Not the ophthalmology, the dental patients.
The dental patients, I'm sorry.
Ophthalmology,
Excuse me,
we
the dental
fortunately
patients.
still have one group that doesn't see anybody, but that's ridiculous. They don't have transportation. And that's happening all over the state.
So I guess what we're saying is, instead of nitpicking this thing or one thing or another, I think the global policies are, for example, say what we saw in Delaware. Delaware, when they moved up their primary care spend, this was based on Starfield's model. Now, Barbara Starfield, our deceased pediatrician, as Judy knows from Johns Hopkins, her work several decades ago says if you put a good primary care workforce in, and people are committed to that, you're going to get better outcomes and lower costs every single time. It has never been disproven in any delivery model, no matter if it's nation-based, state-based, county-based. And so we were saying, if we use that model, how can we use that model to support us? What they did in Delaware was they increased the primary care spend from, say, 3% to 5% or 6%. And what they found when they initially did was they got better outcomes and lower costs. The cost actually went down. And that's a very interesting statistic. Now, the irony was they increased it a little bit more, but what happened was, as you might expect, the administration got a little bit smart to this, say, well, whatever you're going to raise, we're just going to keep it. We're not going to give it to the primary care providers. We're going to keep it with the administration. And when they did that, of course, it didn't work. And that kind of begs our point is one of the policy considerations for you, Commissioner, might be to say, well, if that idea of the Starfield Medical Home model works, and we can support that with our providers, we need to make sure that the resources are going to the providers and are going to administration. And again, I would ask you to take a look, if I'm not mistaken, we could get that to them, I'm sure.
Okay.
But I'm sure AFP, anybody that promotes that type of business, that supports those people are going to have that data. That was very strong data. Yes, Ashima.
So the other thing, that we need to think about is that, as far as access to healthcare, is that if Amendment 2 passes in November, it's going to get much worse with OBGYN and maternal healthcare. So at the KMA meeting, there were some OBGYN residents from the U of L, UK, who had lived in Kentucky their whole life. They went into residency thinking that this is where I'm going to practice, and they testified that they may not stay in the state now because of what's going on, with maternal reproductive rights. So if that amendment passes, it's going to get so much worse. And already in the state, less than 50% of the counties don't even have one dedicated OBGYN as it is. So who's delivering those babies, So that's just another thing.
Well, we had many years ago, I was part of a group of people that tried to place telehealth as one of the delivery models that we would try to use. We did that in Kentucky, and we tried to take a very early claim in that because of the amount of risk that we bear. We're not like Vermont. We just can't wait it out. We don't have a great population. We saw that trying to provide in-person population care, every single encounter all the time, we did not see that as sustainable. So we thought that in trying to move toward telehealth, if we could make this more, I guess the term today would be equitable. If we can reach rural people, if we can reach people that are more disadvantaged and get them to come to the doctor when they need to, or reach out to them and have them available to us, we thought that would be more sustainable. We're still working with DMS to understand, and we're very curious if this gambit that we have played is going to work out for all of us. We don't know. We can only hope that it does, but that was the intent. One of the issues that we had brought up on the agenda today was, Tony, you could help me clarify this. But the intent was when you see something in the office that our insurers, whether it was Medicaid or private insurers, would pay an equal amount in person. The reason it was set up that way is because we do have a group of people that are providing telemedicine from outside, and I'll set them off the table for a second. But when you have a clinic that has to have a brick and mortar, sooner or later with chronic disease care, they're going to come to your clinic. You're going to have to be there. You can take care of some things, and I might be able to take care of diabetes, hypertension, dyslipidemia, thyroid disease. I'm able to do that sometimes, but at some point they're going to come in for a number of reasons. So we have to make that cost, that fee schedule for those providers the same, because they have to pay the overhead. And what they're doing is they're not replacing one for one. They're taking care of this one online. And at the same time, they're able to still see a patient in the office. We're making them more efficient, what we're doing. I think the concern was at some point, if you have these people that are providing simply telehealth from a place with little or no overhead, well, they have little or no overhead. That's not the same. They're not paying Kentucky taxes. They're not living in the Commonwealth. They're not maintaining these structures. And so they're really reaping the benefits. Now, I didn't write that part of the legislation. That was inserted, as you can imagine, by an interest that wanted to see that accomplished. But the other side of that would be is when DMS looks at reimbursing these things, I would assure you that I'm sure when you all look at it, you think of primary care, telemedicine, you're thinking cough and cold. And we rarely do cough and cold through telemedicine. We just rarely do. Really what we're doing is we're doing diabetes follow-up, we're doing hypertension follow-up, we're doing thyroid, lipids, these chronic major medical diseases. That's the way we're trying to follow up with patients. And so we just caution you about trying to reduce the reimbursement for people whose intent was to keep these practices viable. And I don't know the policy mechanism to address that, but I would call your attention to what we are trying to accomplish. And there is a difference here. There's a difference between people that are in Boise, Idaho, God bless them, in their underwear, practicing telemedicine with no overhead, and they're doing cough and cold. And let me tell you what they're not doing. They're not doing chronic disease care because you can't do it. I don't care what they say. I've done this for 15 years. I was one of the nation's leaders in mobile telemedicine. But I'm telling you, you cannot do, when somebody has be it a gout attack or diabetes, you're going to make a change and something's going to happen. And when it happens, you got to go somewhere. You got to go somewhere and see somebody about it, because some problems are going to happen. Or when you do a thyroid, you're gonna have to have a lab obtained somewhere, and somebody's got to follow up on that lab. When labs don't go well, somebody's got to do it, and this has to be done by our workforce. This is not done by the online people. And so I just would ask then to DMS, when you're doing your greater policies, that you consider these things about, again, from Dr. Neal's greater point, who's taking care of your patients and what kind of patients are we taking care of? Is telemedicine Kentucky really cough and cold? Is it really that? Or is it really two sets of telemedicine? You have some people doing very minimal, minor stuff, cough and cold. I mean, it's trivial stuff, minor UTIs, cystitis, and then you have the greater majority of it, which we're trying to move our stable chronic disease care online. That's what we've been doing for really 3 years, is trying to move this stuff online so that we don't have these people in the office basically when they can't get there because of gas, or they won't come just because they couldn't get a ride, or they just were disparaged and decided they weren't going to come today. And there was a hole in your appointment. We're just trying to move them online so that we can take care of those things. Am I on point here? Or am I wondering, Cody?
No, you're on. Yeah,
Okay, let me interject for a moment. I'm, a psychiatrist. My field is obviously set up for telemedicine, and people who can't get into the office, a lot of severely mentally ill, and I'm assuming that I'm an employee of Communicare in Hardin County, and I'm assuming 7 county services would also have the same experience. But you get a lot of folks that they don't show up at the office. Like, well, he didn't show up for the appointment, didn't show up. But everybody has a cell phone, and if I can reach out to them by cell phone, talk to them, hear what's going on, then, if they're stable, great. If not, get a family member to get them in or get them to the hospital. Even a lot of our elderly patients who still are afraid to come out in COVID, or just have a hard time dealing with traffic and don't drive. I mean, for me, we provide a lot of services by telephone and by video chat. And it's been a godsend, and it's helped the psychiatric patients out tremendously, being able to provide care and services for them instead of having them rely to come to the office. But I still have a big office practice and a lot of people coming in. But as far as providing that, and I think you could ask your primary care doctors who practice a lot of psychiatry that don't want to because there's not enough of me out here. If I can do video chats, if I can do telephone visits, it would increase the number of folks that I could see and take care of.
Is somebody from DMS prepared to talk to us a bit about who's taking care? That's one of the things that we had on primary care. One was the spending. We understood that only about 3% of the Medicaid budget is going to primary care. That may be a figure that's not right. I don't know.
I keep hearing that, and I don't know where that figure comes from. And I think what we would need to do when we talk about like new business, the presentation on utilization, on primary care spend. So I think we want to define what is primary care. There's certain codes that we want to look at. I mean, we can look at provider types. And if you look at we submit a report, it's called the Legislative Research Commission report. We provide that to the legislators on a quarterly basis, I believe. And it has broken out every dollar that Medicaid spends. And it is broken out by provider type. However, when you get to the MCO section, it only captures that capitation payment. So if you want to see specific primary care services, we can break those out by code. We can break them out by provider type and by MCO to see where that spend is. But if you tell us exactly what you mean by primary care spend, are there a specific range, or is it the 99213s, 4s, 5s? Are those the codes we need to look at? Is it provider types? What do we want to see? And we can create that report and have it to you before your next meeting so you can have time to digest it and then actually discuss it in the next meeting.
It's a challenge because we all share, unfortunately, as the CPT has matured. I'm trying to think of what CPT codes would be identifiable to primary care, because we all medical providers share the same office-based code. We would share when the primary care does, and again, if you said, well, I'm going to do it by APRNs, well, you may have some like my wife that works in sleep medicine, some work in neurology. You would never really know for sure. I just kind of wonder when we set these things up, remember when DMS was set up, we just never, it wasn't, we weren't thinking this way, and how we try to help you all get your mind around what's going on, we would have to give that some thought. And we have to work with you to say, well, maybe we have to look at our data differently. Can you think of anything off the top of your head, Cody?
Yeah, to give it some thought. Is there someone in the DMS that we could communicate back straight to you?
Yeah, talk to me and let's get some reports designed and routine reports that you want to look at. So for example, we have been looking at top procedure codes, top diagnosis broken out by MCO, broken out by fee for service and by adult and children. We know, for example, that one of the top procedure codes that for MCOs is deliveries. I mean, because we cover over half of the births in the state in Medicaid. So of course, one of the top procedure codes is going to be the delivery of a baby. We know that the diagnosis codes for our population in fee for service are vastly different from our population that's served by our managed care organizations. Now we have that data from 2020 and we can update that for 21, 22. If you want to look at some of the top diagnosis codes and procedure codes that are being billed we have it based on volume and based on dollar amount. So we can get some of those codes and just looking at what the top services that we're providing will give you a little bit of insight. And then we can break it down further. If there is a specific set of codes that will help us get to the primary care spend, then we can do that. But I think just looking at that information from the diagnosis codes and the procedure codes will be very helpful for you all.
One person you could talk to would be Jerry Stover. You know, Jerry might be able to help us because maybe we can talk to those people. I'd be interested to talk to people in Delaware. How did they figure out what their primary care spend was? You know, I bet they were set up very similarly. I kind of want to know if they were able to find the data, how did they mine that data so that they could have insight? But I guess one of the things that you're really making the point that I think we're stressing, at least with the primary care workforce, which is, you know, primary care is delivering babies and they are doing the ER work. They are doing the chronic disease work and they are doing part of Dr. Linden's behavioral health. And, you know, it's not just one thing. You're asking them to do a lot of things. You're asking them to do preventive medicine. It's primary care is being treated on paper. It's just, you get this service and they're doing this code, we're doing this baby, we're delivering that amount of money, but you're asking them to do a lot of things that aren't being accounted for with codes. When they come in for their thyroid, we are trying to say, well, is their cancer screening up to date? Is this up to date? Have their immunizations been up to date? Have we talked to them about getting a COVID vaccine? And all this takes time. And I could be mistaken. I don't need to be flippant here, but did they not come out like about a month ago and said that the average, if you did everything you're supposed to do in primary care, like the average day was like 27 hours. I mean, it was a crazy number. Like if the primary care doctor did all the stuff that you want them to do, at the end of the day, they would be working 27 hours every day. And so I would ask you, when you begin to think about this from an architectural point of view, is you just can't consider primary care like my neurologist or my ophthalmologist or my rheumatologist, because they come in, they're doing what they're supposed to do. They're taking care, even Dr. Linden, they're taking care of these very sick people that we cannot address with primary care. We cannot be done. We have our system set up this way to do it efficiently. But you can't look at it because we're not doing that job. We're doing part of that job, but we're doing other jobs too. And I think that's what Dr. Neal pointed out when at one point we had Kimpact, this per member per month, it wasn't a gift. It wasn't so much, it was more of a subsidy to say, we recognize you're doing all these jobs and we have to have a way to compensate you. There's just no other way to do it because there's not a code for it. You know, if you did that, you'd spend all your time coding, that's I really am at a loss for vocabulary to try to explain the role that you're asking them to do for you. But what we're saying is we've been kind of saying this really for 4 or 5 years, but Dr. Neal's right. It's coming to the position where I'm afraid what's happening here is we're going on the other side of this and we're beginning to get into a position where we are not going to become sustainable. And sometimes in government, that's very hard because you're on a budget. You know, you might work at the pleasure of the legislature or the executive branch, and these things change. But you know, we have to have some type of long range planning. And once things go bad, like the people that are your friends now, well, they will be your friends when things go bad. I mean, if there's nobody to be made here in Kentucky, they'll leave. and then it will just be us. And you'll say, well, then we'll start treating people better. It won't matter by then, because then you can't get, it would take you generations to try to populate these health providers that are doing your work. And unfortunately, we're not a very urban commonwealth. We're a very rural commonwealth. We have 2 or 3 or 4 or 5 cities. We have a lot of people that aren't, and this is where the business, you would call it in what is it, in the last mile. You know, when we talk about Kentucky Wired, the last mile is the expensive mile. Well, that's what's happening. This last mile is beginning to fray. And so we want these big architectural changes, like, well, what's your primary care spend? Do you want to bank on Dr. Starfield's model or another model? But you're going to have to pick. You know, when we talk with telemedicine, are we going to use ways to use telemedicine appropriately to try to save us money and invest in your Kentucky providers and treat the people that aren't in Kentucky, that aren't paying taxes, that don't have that overhead? Should we treat them differently? Well, I would submit that they are different. Now, how we want to treat them is a different mechanism. Can we do things to support the primary care workforce that is really taking care? And these people are not costing us.
One thing I would think that you might be able to do is to look into more, and especially if you're looking at the spend, is looking at value added services.
Oh, boy. Are you bringing up value added services versus fee for service? Are you getting into that, please?
Well, I'm thinking of value added services for primary care, because our MCOs do have programs, and they can develop programs that will help basically reimburse you for what you're doing over and above the typical visit.
That's been a very difficult starter, particularly in pediatrics, I can tell you. We're trying to move from fee for service over to value-based care. It's just, we've been working on that for 10 years, and I don't think we've scratched the surface of it. Maybe more in adult care, I don't know. But I have to keep reminding myself that we're just talking about Medicaid recipients here. But can you bring us up to date? When I started in practice, Medicaid was a very small thing, and it was a safety net. It's now gone way past being a safety net. What percent of Kentuckians now, you know, I think it's about 60% now. Children on Medicaid is about 60%, 40% adults, but the cost is that 60% of children is only 40% of expenditures, where the adults are costing much more. Children don't cost Medicaid much. Is that still true?
We have some data that we can share. I'll pull some information together on where the spend is. We do have, our top spend, of course, is in some of our waiver programs. We have a few, I have a chart that breaks out that the spend, for example, the bulk of our adults, we have actually broken out in individuals, the number of individuals. For example, I know that we had in 2020, we had 23 individuals that we spent over $1 million on in the Medicaid program. And then when we go down further, we have the bulk of the individuals in Medicaid we spend around $1,500 a year on. So we can identify those individuals. And I actually looked at the 23 because I thought they would all be in our fee for service and our waiver programs, but they were NICU babies. They were hemophiliacs. They were not, I mean, there were some that were in our fee for service population because those individuals are more medically complex than our others, but we can definitely get that information to you. And I just want to, what can we do? And what information do you all need to help us look at our policies and make those changes that are going to have big impacts? We can definitely get information to you, whatever information you want.
What percent of Kentuckians are on Medicaid, for example?
1 out of every 3.
What?
1 out of every 3.
1 out of every.
We have 1.6 million, almost 1.7 million on Medicaid. But now we got to think that right now we're in this maintenance of effort due to the public health emergency. We cannot terminate anybody from Medicaid unless they ask to be terminated or they move out of the state or they die. We cannot terminate anyone in Medicaid right now. So again, 1 out of every 3 individuals. We have a little over 4 million individuals in the state, and 1.6, almost 1.7 now are on Medicaid. And I think that you talk about how Medicaid has changed, and it's because Medicaid has become the go-to program to solve medical problems that private insurance cannot or will not address. And that's one of the reasons, when we talk about the number of individuals on Medicaid, it's nothing to brag about, because those individuals they live at or below the poverty level. We keep being asked to do more because, again, commercial carriers will not. They have limitations. They have out of pocket on a lot of their services than for example, therapies for children. We have on our waiting list for our Michelle P. waiver program, half of those individuals are children because they can't get the therapies that they need in a private insurance. And the waiver programs are designed the eligibility is based on the child's income, not the family income. So we have individual children who are waiting on our programs who may have private insurance, and their family income will not allow them to get in Medicaid to get those additional services. So they are on a waiver program. And those are some of the issues that we have to address. It's Medicaid is asked to cover what commercial carriers cannot or will not cover.
Well, I would submit, I would say we feel your pain. I would submit it's worse than you're saying. What I would say is we may be 1 in 3 in Kentucky has Medicaid, but I would say for every one person working, you have one person on Medicaid. That there's a group of people that aren't working that are senior, and we don't even count those people, and that's not sustainable. You can't have one person working and say, I'm gonna take care of my insurance, and I'm gonna be enough to pay for this Medicaid person. On top of that, I mean, it's like one provider in a family's taking care of 2 families, and I just don't see it sustainable. So we feel that the dire urgency to try to make this thing more sustainable for all of us.
Is it time for a workforce of some sort? You know, Emory Wilson put together the Institute of Medicine about 15 years ago. Do you remember anything like that? I got in on it at the very end, and I was just talking to him at our KMA meeting, because that was a meeting of the thinkers in Kentucky from all sources, from the medical schools, from government, from everything, trying to put together some sense of sustainability for this, because we haven't gotten off 48 to 49th on anything with everything we've done as far as health.
And yeah, and we talk about that too, how our health rankings, and that's the entire state. It's not just Medicaid, it's the entire state. So we are looking at workforce development. We did a workforce development study back in 2014. We're dusting that off and trying to update it. But I do know that public health did a workforce study, but they only focused on a few provider types, dentists, primary care, those sorts of things, OBGYNs, I think maybe pediatricians. They do have a workforce study on their website that I can send you the link, and we can kind of look at that, maybe something in here, but I don't know that it may have some recommendations on what needs to be done. For example, when we talk about the dental population, you know, both UK and U of L only graduate so many dentists each year, and you know, can we increase that, or how do we entice providers to come to Kentucky or stay in Kentucky? Are there programs, you know, and I haven't followed up lately, but I keep hearing about, you know, that there was a program at Pikeville University or University of Pikeville where they were trying to identify individuals in middle school and high school that maybe had aptitude for medical, and trying to help get them into that school early on and keep them in that region. So, because they would be more likely to stay in that region. I haven't, you know, followed up with that. I don't know if there are any other studies or any other documentation that we can look at on what they're doing there. But how do we do that? How do we grow our own here in Kentucky?
What's the question might be better phrased than what we spoke to earlier. It's not how many people we're training. We could train triple the amount of people, but if the environment isn't where they can afford to stay economically, they're going to leave. They're just like you. They're smart people. They spent 15 years in college. They're going to get out. They have a substantial debt. They're going to say, well, I'd like to stay, but you know, I don't have a mentor back here. I mean, the doctor that I knew, they're not practicing anymore. And, you know, I mean, I'm not sure my wife wants to live here, or my husband wants to live here anymore. We're going to go down here and live. So you can train more of them, but they're just going to leave. Right now, we are exporting doctors.
And that's the problem. I mean, medical school is $40,000 a year for UK in state. And so once you, and that's just tuition. And so you accumulate this huge debt, and then you have to pick, do I want to go into ophthalmology or primary care? And, you know, you're going to be able to pay off that debt a whole lot easier if you go into ophthalmology or, you know, a subspecialty than you will in pediatrics or internal medicine. And I think those are real life issues that our graduates are dealing with. And so a loan repayment is a wonderful opportunity if, you know, if we can do that in some of our rural communities. And hopefully once we get the person there, they will end up staying. You know, but that is something we can look at, and it's something that some of our communities do to try and attract new graduates.
I've talked to a lot of primary care doctors over the last 3 years that I've been working in the summers in various clinics. And I was surprised in that income is not the primary problem for these primary doctors right now. It's not that they're making enough money, it's the conditions under which they're working. Because the electronic medical record has gotten them to where they don't have lunch anymore. Lunch used to be somebody coming in and lecturing about a new drug or a new therapy. Now lunch is catching up on the computer from the morning and taking it home at night, getting their kids to bed if it's female pediatricians, for example, and then going back to finish up the computer work from the day. That makes them unhappy. And they're talking now about giving more administrative time to physicians who already are not seeing enough patients to keep them from being way out a couple of months. In other words, if one of your Medicaid recipients calls and wants an appointment, they can say, well, the doctor's booked up for 2 months, but you can see maybe PA, nurse practitioner, within a week or something like that. And the dentists are having the same problem. They're producing more, but with more, and nothing, not being sexist about it at all, but a lot of the females are working part-time rather than full-time. So as one dentist described it, we have more dentists, but we're having less dental days worked. And I heard that over and over and over, and that's happening also in other primary care. Would you agree?
Well, I would say that the wisdom in that piece of information would be that we're in a new time of medicine. What many of the people that are on the call may not understand, when you work in this type of medicine today with where we necessitated EMRs, you might spend $100,000 to get the EMR, okay? But that's not what gets you. What gets you is the $5,000 or $6,000 a month every single month that they want, and that goes up. And when if you don't pay it and it breaks, they're like, well, we're not going to help you. And so you can't do that. It's basically, it's extortion is what it is. It's legalized extortion. And they've worked their way into the medical industry. And now that they run that. And of course, there's no code for that. See, I can't code that I have to use the EMR. The EMRs do slow us down. This is not DMS's problem, but we want to let you understand that we're trying to work. It's like we're trying to work, but we're working in quicksand. It's like that swimmer. We're asking them to put on more and more clothes and the water's getting deeper. So when you promulgate policies, we hope that you'll consider these things, that we're doing the very best that we possibly can. But they're just not coming in for a cough. They're coming in for COPD exacerbation. And we're trying to talk to them about tobacco cessation, because we have the #1 tobacco per population in the country. Well, by the way, we have #1 colon cancer and ovarian cancer and breast cancer. I mean, you know, this is, where does it end? And so all these things are not codable. There's no code for we're gonna do this so we can get a little bit more money. We're just hoping that when you look at these things and you look at your primary care workforce, that you do things that can support the workforce, because we think that those people, short of generic medicines, I would say it is by far the most valuable resource and cost-saving mechanism we have. And we have to invest in it, because I don't see any other way out of it. I don't see any other way that we're going to become sustainable except through a primary care workforce that can do that work for you. Yes, ma'am.
Not even just primary care. Dr. Terry, you're talking about ophthalmology versus going up into ophthalmology versus into primary care. Within the ophthalmology world, all the pediatric subspecialties also facing a huge shortage. So pediatric ophthalmology, those spots do not fill for a fellowship because they keep, first of all, you can't see as many patients. You don't do as many surgeries as a general ophthalmologist. And the CPT codes for strabismus surgery is gonna be cut starting in 23, at least federally. And some outpatient surgical centers are no longer allowing adult strabismus surgery. So in Louisville, for example, we are 4 pediatric ophthalmologists. I think Norton just hired someone who started 2 days ago. 2 of the pediatric ophthalmologists, one is 80 and one is in his late 70s. And one can no longer perform adult strabismus surgery because where he operates, they said no more because the surgical center will not make any money on those cases because they're cutting the reimbursement. So this is a huge problem. I'm starting to see more of those adult strabismus. Those are definitely much more complex patients. My reimbursement is going to be going down and I face more liability also with those patients. And now we are going to be having, if everyone hears about this, I'm sure like slowly it's going to trickle into where I operate and they might say, sorry, you can't do these cases anymore. We have a whole subset of patients now that are in the workforce suffering from double vision who cannot get surgery. So this is a trickle effect that we can't fill these spots, any pediatric subspecialty spots. There's the residency group right now, the 3rd year, final year. One was applying for pediatric ophthalmology. I just saw her last night. She says she's thinking about just becoming a general ophthalmologist because she does not want to work in a children's hospital. And that's really the only place where you can actually make any money by being employed by a children's hospital. I mean, I'm in private practice and there's no way if I did 100% peds that I'd be able to survive. So that's why I have to do, half my practice has to be adults to sustain that pediatric practice. So this is what residents are facing, even in subspecialties, when they want to choose whether to do pediatrics or not. So it's just going to continue to get worse.
Well, let me say this. We've heard nobody wants to hear wants to hear you whine. That's what I'm not the first person to say this. The ancient Greeks said this, Marcus Aurelius particularly, but I think we want to get away from the whining point. I think what I want to try to point out to you is this, aside from all the particulars we've talked about today, is I want you to notice that over the last 5 or 6 or 7 years, what's happened. We used to come to this committee to try to say, we have this little point we need to solve together. We have this point, we need to rub out the edges on this one. We come in to talk about those things. But we have a few little things about whether telemedicine reimbursement is going to be appropriate for us. But really what we're talking about are these very, very large issues. And I don't know how to I really don't even know how to counsel the commissioner. I almost feel like I'm working for you and saying, I don't know how to give you good counsel to say, should we have an institute of medicine? Should we be talking to the secretary or the governor about, we're coming into a major, major crisis and it's not clear to us where we are in the crisis. It's like when you're going through the middle of the war here, it's getting very foggy and we may have already gone off the end. I mean, maybe we've gotten to a place we can't get back from. We just don't know, but we know it is very serious. And we cannot tell you how to run your business, but we can say primary care looks like for us the best salvation to make us sustainable. If you can work with your MCO partners, the ones that we work with, if we can find a way to try to make that sustainable for our Commonwealth, we think we have the best chance to control the chronic disease care. We don't think we're just out here spouting this. We think that Barbara Starfield's model does give us insight into the way to solve this. We hope that the smaller policies will come into line with your bigger policies, and we would have to work on those. But I think it's about time that we're going to have some major policy considerations about what the Commonwealth is going to do. And that's the best counsel that I can give you. And that's not, it might be self-serving counsel. I'm not even sure it's self-serving. It's just, I'm just a member of the Commonwealth and I worry about my children and what it's going to be like to live here. And to put an explanation on this, we haven't really talked about this, but imagine if you were a business owner with $1 billion company wanted to come to Kentucky. Well, what does that mean? Well, who's going to be here to work? And who's going to be able to take care of my people? And what's my healthcare costs going to, I mean, it's hard to ask $1 billion company to come in here when I have Tennessee right beside us, or to the north, I have Indiana saying, we want that business. And by the way, we're healthier. Our people are healthier. We have people for you to work. They're going to show up for work. Well, we're part of the people that makes us competitive. And we're trying to implore you to consider, again, we're not talking about teeny tiny issues anymore. We're talking about catastrophic issues and how you all are going to handle it. And I just don't know, Commissioner, what to tell you. I don't know who you talk to. I mean, I assume people have it bad as we do, but not very many. Maybe Mississippi can, you can throw in with them. But we have the 49th most obese children in the country. We're 40, whatever our health is, it somewhere starts at a 4 or a 5. And that can't be good. And the only people that I can see that has been proven decade after decade to solve this problem for you is your primary care workforce. And somehow we're going to have to support those people and how they do it and how they do their job. And that comes to, well, let's look at how prior authorizations, are we going to still put this on the onus on them? Can they do their job at that? Or what happens now, which is, well, you don't give us the permission to do prior authorizations. Okay, we just send them to the ER. Or we send them to the specialist to get the opinion, and they send it back and they say, well, we've got that's what happens. We're just spending money twice. And so I ask you to, when you go home tonight, just to say, that was a really unusual meeting we had. What are these guys talking about? And this is what we're hearing. I mean, am I wrong in any of this? No. And this has not been going on for like 6 months. This has been going on for so long that I don't even have the vocabulary to try to express it to you.
Well, I understand exactly what you're saying. About our workforce, about the health of the health status of the population we serve, the number of individuals on Medicaid. And this isn't just a Medicaid problem. It is not just a Medicaid problem. And who else do we need to get at the table? How do we get everybody at the table to say, we have this major workforce shortage issue that's going to come to a head when all of our children get X age, or when the adults start aging out. We also need to have individuals to take care of our elderly. We need to have how do we get that, and how do we build a sustainable workforce? Primary care, I think, is everybody has to have primary care. It should be the biggest delivery of providers in our state. When we get down into the specialties, when we talk about, for example, pediatric ophthalmologists, I mean, it's not sustainable, I don't think, to have one in every single county. Would it be great? Yes, it would. But the very small volume of individuals that would need those specialty cares, or that specialty care, is not sustainable. So I understand what you're saying, but what data can Medicaid get, and who else do we need to be at the table to try to start solving these problems? Because this is a big, huge, monstrous problem, and how do we start taking bites out of the big pie so that we can just kind of get some sort of recommendations and get some things in place to know where we are now. And this is what I keep asking everybody: what's our baseline? What is our baseline? And we don't have any data to show what our baseline is. Right here, we talk about all of the issues, but we never get our data together to say, here's what we're showing, and this is what we recommend based on this information. So how do we get our baseline of where is our money in Medicaid? Where is it going to primary care? How much is going to primary care? How do we get that baseline to show it needs to increase? And then how do we move from there? But we don't have our baseline.
That's what I was asking for today, for you all to think about that, and we'd like to work with you on it.
Yeah, help us design whatever, and I can bring some information. I can share information that I have pulled. And one of my first priorities when I came back to Medicaid was to get an annual report, a Medicaid annual report. It took a while to get that, and we started on it. We've got a 2020 draft, but it's under review for us to publicize or make public. And I think that this committee, and not only this committee, but every TAC and the MAC should look at that report and tell us what they want to see in it going forward, so that we can identify. I mean, because we've got, and again, 2020 is already 2 years old. we can update that report, but I don't want to update that until I get input from committee members. I don't want to deliver another report, but that report does have in there. It has eligibility trends by county. It has the number of enrolled providers. It has the procedure codes, diagnosis codes broken out by children and adults and managed care versus fee for service. And I think it gives you a good picture of the Medicaid population, but it doesn't tell us how much money is being spent on primary care. So those are the items that need to be put in. And if we have something like that, I mean, we could even create a quarterly report. Some of the things that we've been doing in Medicaid that I feel are so great that we don't get to talk about a lot. I mean, we serve 1.6 million people. Our budget was about $15 billion. That's a lot of money to be spending.
Can we pick out the primary care by taxonomy code?
Yeah.
Like start there, and that would be different for like nurse practitioners. Would it be different? I mean, is the taxonomy code different for say like a pediatrician MD versus like an NP who works in pediatrics? Would that be a different taxonomy code?
I don't know. Is anybody on from
They're working
Jennifer's?
under the same codes.
I mean, like, I know for like
Primary care.
ophthalmology, we have a taxonomy code, and it's like pediatric ophthalmology, there's a different taxonomy code. It's like, it goes with the NPI number.
We can pull out, we can look and see, but again, it's where, and how do we, what do you want to look at? What specifically? Because if I go and just pull, by primary care providers, I mean, we have specialty codes listed in there, we have pediatricians, we can pull that, but what data is going to be useful for you? What's going to be,
Well, let us work
We don't
on it.
know what you know,
Yeah.
and that's what we.
Well, let us work on it. We can maybe at least work through with K. The only people that I can think of on our side of the table would have the resources to even consider it. Would be someone like a KMA. Maybe you might be able to talk to the KAFP, but maybe we can work on our end to try to look at other people and see.
anything that's on a claim form we have.
Yes.
Anything that's on an eligibility file we have, anything that's on a provider application file we have. But I think the claims data is where you're gonna get the information. So anything that's on our claims data, and we can look at, you've got inpatient, and that's the thing, 1.6 million members, we have a lot of data and a lot of information. And it's not just pulling that information, it's how do we pull it out and put it in a format that's digestible for just the general population or for our legislators, for example. How do we pull that out and make it digestible?
As I said here, I remember my years on the MAC, and I think about, we're just talking about the primary care right now. Then I think of the pharmacists who are in a world of hurt because of
PBMs.
managers and all that sort of thing.
PBS
The home
providers.
health people, the therapists, the primary care association. We've got all these stakeholders that are sitting there saying, how do we change this? How do we survive? And we're all in this together. So, and then you throw in a tornado in the west and flood the east, and where the heck are we? So I
like your
think we
vision.
make some progress.
Should we be considering, and maybe we should come back with some type of proposal for you just to at least go against the wall. Should we be considering some type of medical summit in the Commonwealth to look at, the future of how we're going to do things and what stakeholder, aside from just DMS, I mean, there are other major stakeholders of what is our governor, what is our legislature, how are they going to, how do they want us to solve this problem? Because it's come to the point now where it's going to begin to affect all of us. We're all in the same boat, and the holes are starting to pop up everywhere. And I think that we're the ones that we're going to have to solve this problem. I think we should give it some thought on our end. We should just come in here, and I don't intend to come here to complain to you. I don't intend to do that. But I do want to come up with some solutions. If we're going to come in here, we need to come up with some options for you. And I think that we can, on our end, this might be a golden opportunity, an inflection point in the Commonwealth when we can say, this might be something to consider and present it to you so that you can kind of digest it. You have experience that we don't have. And then from there, we can decide what the best next thing to do is. We'll continue to come and try to do the work we can with the small particulars, but I just can't see the future. I mean, I can't even see to the next meeting. I can't see, well, what can we ever talk about besides these things, because they become so dire.
And what, yeah, and again, going back to that, what is our baseline? What, and I keep saying, you know, we can look at, you know, our health status and our rankings and, you know, all the reports, but they're gonna always say, if we're even making progress, other states are making progress, so we're still gonna always be pretty much at the bottom, but where have we been over the past 10 years? Where do we wanna go? What are our major issues? And I don't know that we've ever, I haven't seen that baseline of information of this was our health status in Kentucky, and not measure ourselves against other states. But here's where we were, here's where we are now, this is where we've not improved based on our information and how we get that. You know, Medicaid has a lot of information, but just looking at the Medicaid population is not gonna tell us, it's not, we're gonna have to look at, and how do we get that? How do we get that information to start looking at the entire population? Who has it? Does somebody have it right now? Can we get it? Can we measure where we want to go? We want to, you know, we want to reduce, I know we have issues with maternal mortality. Do we want to reduce, what are we gonna do? What sort of interventions are we gonna implement to reduce maternal mortality? What are we gonna implement to reduce colon cancer? I think that we have made, that's one bright spot. We have made a lot of progress in colon cancer when we implemented Medicaid expansion and more individuals started getting screenings earlier. We have greatly reduced colon cancer. So how do we get that bigger picture, and what do we want to measure in Kentucky besides colon cancer, maternal mortality, diabetes, you know, all the things that we know are killing us? How do we get that big picture, get our priorities, and then move towards improving the health status of those we serve?
We'll work on it. We'll work on
It's
it.
a big task, and it's not, you know, it is, it's a huge task. And if we can, because with our data, with our Medicaid data, we can go back in time and we can say, what did the Medicaid member look like at this point in time, and what do they look like now? Have we gotten worse or better? And we have to look, you know, again, it's a lot of measures. When you look at, you know, diabetes, heart disease, COPD, you look at children versus adults, it's just, it's almost impossible to get your arms around everything that we can look at, and we can make, you know, design interventions, but what are our top 5 or top 3? How do we get there, and how do we know what we want to move towards?
Well, let us work on it. We have 3 big pools of data. We have Medicare data for the aged, Medicaid data, and we have private information data. And let us think about, with our population health experts, the best way to try to put this in front of us so that we can begin to have some, you're right, if we can't measure it, we can't administrate it. So let us work on our end to try to give you counsel on the best way for you all to be able to make good policy for us. Now, Cody, I don't want to tie up the commissioner's time. I want to be respectful. Was there one tiny item that you wanted to adjust? What was it?
There was one question on the 907 KAR 3170.
What's that?
Jonathan Scott's. That was the audio only telehealth.
Jonathan, can you hear us?
Yes, you can.
Yes, sorry about that.
Hey, Jonathan, Cody had a query for us. We have one item we want to do before we head out of here. What was it, John? What was it, Cody?
Jonathan, it was the telehealth reg that I reached out to you about previously. It was on it's 907 KAR 3170. It's the audio only telehealth visits where they could be reimbursed for some of the existing telephonic codes.
Yes.
You sent me the codes that those would be that would encompass those. Because and I talked to some more of our physicians, and could you just kind of further elaborate on, I guess, the scenarios or types of service that would fall within that range?
Sure. It's just the telephonic codes that were, and of course I've forgotten the numbers. So, but it's those telephonic codes that were allowed at the beginning of the pandemic that are those E&M codes So there's the 5 to 10 minute one, and there's the 10 to 20 minute one, and then the slightly longer one that goes out to 45 minutes. Those are the only ones. So in the Venn diagram of audio only telehealth and these codes, that I guess it's really not a Venn diagram. It's just they're this tiny part here, and then everything else is the allowable audio only telehealth. And the reason we do that is when you read House Bill 140, I think it's possible that you could face a enhanced documentation requirement for telephonic services, for audio only telehealth, right? The MCOs might be able to tell you, we could maybe tell you, you need to document why, an audio visual service wasn't performed here. So when we do that, we wanted to carve out these E&M codes that are already being used via telephone, already telephonic, that you can just do those, right? And so we've introduced them into the program for the first time in the reg, and there's not an enhanced documentation requirement on it. You can pick up the phone, the recipient can pick up the phone, and you can just perform that service. Does that help?
Jonathan, let me give you, this is Chuck Thornberry. Let me give you an example that would be very common in our office. So we have a patient, say this serviced by a beneficiary of DMS, and they have diabetes, high blood pressure, and high cholesterol. We've been through this several times in the office. We feel like that the last time we saw them in person, we probably want to move them online if we can, because they were doing rather well. We're going to go over information like their A1C. We're going to go over their top blood pressure number, because we know that these people are taking care of it at home. We've kind of seen to that. We're going to go over their lipid numbers and their compliance. We're going to work on all this. Generally in the office, anytime we have 2 chronic diseases that are stable or more, that's a level 99214, okay? Now, when we wrote when I helped write the legislation for that, the intent was that if you did something in the office, that online, whether that would be audio only or audio visual, that you would be compensated the same, because we were trying to help Kentucky providers keep their business, and whether they're carrying the same liability, you understand. Now, we were doing it audio for a lot of people, because whether we see them in person, whether we see their face or not, it's not like, say, Dr. Linden. Dr. Linden takes care of complex behavioral health. These people are ill. You have to see their reactions. With us, if I'm talking about somebody's thyroid or their diabetes, I don't have to see what their face looks like. I can hear by the intention of their voice, or if I can't, I got to bring them in. But the point we're trying to say is, if we're going to be paid something here, is it equivalent to this? I want to make sure that I don't want to try to skirt the rules that you're setting, but I want you to understand the reality of what we're trying to do. We're taking full liability, and if we can't do it, then we have to decide whether we can do it online or not. But for many people, we can.
Would that be remote patient monitoring codes rather than the 99213 or 99214?
We would only use those because, one, to me, they're expensive, and two, I do that only when I have to. If I have to monitor their SATs, if I have to monitor something, then there's a reason for doing it. It was kind of an area where people try to get you to move into it to make a lot more money for your practice. But most of us in primary care try not to utilize that unless it's absolutely necessary. So we try to just keep things as simple, as straightforward as we can, because the more complicated you make it, it might be more expensive. You may drive more revenue for your practice, but it doesn't solve the patient's problem. That's what we're there to do, is to keep it straightforward and simple. Does that help you, Jonathan? That's kind of my acid test. If I'm doing a metabolic X in the office and I'm beginning to pay it online, now whether I do it audio visual or not, that's really up to me. But now I'm carrying liability for that. You could be in front of the Board of Medicine or in a litigation, a med mal litigation, depending on how you decide to handle it. We have a court system that does that. If you can handle it by phone, we try to do that because most of our patients are more comfortable with that, particularly the aged. I don't know if that helps you in your understanding of how we're trying to work with this. Yes,
Dr. Terry.
So my question is, for the documentation, I think you would just write your standard SOAP note like you would if the patient was in the office, and then put the time that you were on the phone.
Yes, ma'am. That's what we're doing, Dr. Terrio, is to try to help. We're trying to say, well, it does take a little bit more counseling time, but here's what I found out. They don't miss their appointments. You know what? Because a lot of people, a third of them were missing it. It's worth the time. And their A1Cs to us are better. They look better overall.
Yep.
We're getting value for it. That's what we believe, or we would stop doing it. We would just say, well, you need to come on in. I don't know if that helps, Jonathan. We want you to kind of understand where we were, okay? Now, that's different from the call where I think when this was first intended by Medicare, well, how you doing? You doing okay, Ms. Smith? Okay, we're just checking on you. That's really probably the way it was built, but that's really not what we're using it for anymore. I mean, we've taken that ship or that car and we're not driving to the post office, we're driving to Bowling Green with it, you know?
Sure.
Okay.
And has the reimbursement for that increased?
I'll be candid with you. It's my practice is so complicated. I don't even know.
Okay.
I would do my own billing. That has to be done out of Virginia.
Okay.
All I know is we're like, are we getting good information from the patient or not? Are we taking care of it or not? I just try to deal with the day to day. I'm still the old guy that does only the doctoring part. I'm not that sophisticated. I'm sorry.
I do think those telephonic codes are very, very important because a lot of times you spend just as much time on the phone with the patient as you do when they're in the office. And it's a big deal to be able to deliver that service by the telephone.
But Dr. Terrio's right. And that's what I want you to understand is by doing the telephonic audio only, we're not trying to skirt anything.
Sure.
And the truth of it is there's a politically sensitive part to this. If you don't provide that, you start to run into someone's going to complain about equity or something. And we have data now that says we're getting good outcomes, but I want you to know that it looks like from our point of view that we are getting these good outcomes. That's what I got from the last meeting. And these big meetings with KMA, you rub into your colleagues a whole lot. You start talking about Jessica, well, how's it going with you? What are you doing? And that's the vibe that I'm kind of getting. And if we were getting something different, we would probably have to tell you that it's not going the way we are. The thing that makes me the most anxious is what we talked about earlier this year is we placed our organization, the physicians have placed a huge amount of our prestige and our belief that this telemedicine will work for us. And I'm going to be not only heartbroken, I'm going to be fully disparaged if this doesn't work out the way we hope it does, because this is our opportunity to go from dirt roads to 5G. You know, that's what they did in Nigeria. They just skipped all the middle stuff. And if we can do this, we're going to be leading other states. Other states have already come to us to look at our policies, but we need to be able to say, can the commissioner show that it's working? And she's right. We're not sure, but we're anxious about it. Well, I unless somebody has something else, we're at 1:30. Yes, Jonathan.
Well, I was going to mention, looking back at your old business, 907 KAR 3010, the complex E&M office visits, that reg was filed this week. It was filed on Tuesday. I just haven't sent out the reg watch email to everyone yet.
I wasn't really pushing you on that. I think it was just on our agenda. We want to, of course, support that. And while we have obviously material resource supporting that, but really we're trying to do that because we think it's going to be toward the long-term goal of sustaining us. And that's why we're most interested in it.
Well, it's also complies with standard billing practices.
Well, we're doing the work and taking the liability. We just felt like with that. And again, we just want to keep an honest partner honest.
Yeah.
And
So, yes.
can you bring me up to speed real quick? What's the change? What's the proposed change on that? I haven't heard what that is, and this is my first meeting.
The proposed change, and I think Jonathan, you may have Kelly, but typically we only allowed 2 codes per year of 99214, 99215. And then when they came into the system, with more than 2 came into the system, we would pay a lesser charge. And now we have just taken that language completely out. So there are no limitations on the number of times those codes can be billed per year. So just want to make sure too that we've made the system change to allow those codes in the system with the filing of the reg.
That would be fantastic. My office manager would be happy and quit hunting heads.
Well, I want to thank specifically Jonathan and particularly the commissioner and her staff and our MCO partners in helping us work for that. This has really been a team effort, and I appreciate everybody helping us get that accomplished. If there's nothing else, again, I want to be respectful of everyone's time, and thank you for allowing us to meet in person. It's really good to see everybody again, okay? Nothing else, we'll call this meeting adjourned. Thank you, everybody, for coming.
Thank you all.
Thanks.
Thank you for driving in, Ashwin. Thank you, Commissioner.
Well, you're very
I
welcome.
know that you didn't stay for that.
Well, it helps to kind of